Hello everyone. Welcome to today's session on central venous catheter and peripherally inserted central catheter line care. Central lines play an important role in the management of critically ill patients, providing reliable access for medication, fluids, nutrition, and monitoring. However, with these benefits also come risks, especially infection and complications. In this session, we will review the principles and best practices for caring for CVCS and PICCS so that we can provide safe and effective care for our patients. Here are the learning objectives for this session. By the end of this class, you should be able to, first, understand when and why a CVC or PICC line is needed. Second, recognize the differences between a CVC and a PICC line. Third, review the essential care protocols for daily management. Fourth, learn how to prevent common complications associated with central lines. Finally, emphasize patient safety, which is always our top priority. A central venous catheter, or CVC, is a catheter inserted into a large central vein, most commonly the internal jugular, subclavian, or femoral vein. The catheter tip is advanced until it reaches the superior vena cava, which allows reliable central venous access. CVCS are generally used for short to medium-term therapy, such as administering medications, fluids, parenteral nutrition, or monitoring central venous pressure. Insertion is performed by a physician or a trained healthcare professional, as it requires sterile technique and advanced skills. CVCS come in different sizes, with single, double, or triple lumens being common, and even up to 5 lumens when multiple infusions are needed. Finally, chest X-ray confirmation is required after internal jugular or subclavian placement to check tip position and rule out complications, but it is not needed for femoral placement. This slide shows the common insertion sites for central venous catheters. On the upper left, we see an internal jugular central line, which is one of the most frequently used sites. On the upper right, a chest X-ray is used to confirm the position of the catheter tip after insertion, especially for jugular and subclavian access. On the lower left, we see the subclavian central line, another common option that provides stable access but carries a risk of pneumothorax. Finally, on the lower right, there is the femoral central line, which is easier to insert in emergencies, but it has a higher risk of infection compared to other sites. This slide summarizes the steps for inserting a central venous catheter, usually using the Seldinger technique. First, position the patient, often in the Trendelenburg position for jugular insertion. Second, prepare and disinfect the skin using chlorhexidine or povidone iodine. Third, insert the introducer needle and confirm entry into the vein. Fourth, insert the guide wire, then advance the catheter over the guide wire. After placing the catheter at the correct depth, remove the guide wire, flush all ports, and secure the line with sutures or a securement device. Finally, confirm the catheter tip position with a chest X-ray, especially for jugular or subclavian lines. On the right side of the slide, potential complications are listed. These include mechanical complications like hemorrhage, pneumothorax, or arterial puncture, infectious complications such as bacteremia or cellulitis, and catheter-associated complications like thrombosis or stenosis. Now that we have reviewed the characteristics of a CVC, let's move on to another commonly used central line, the PICC line. A PICC line is a long central venous catheter inserted through a peripheral vein, most often in the upper arm. The basilic vein is the preferred site, although the cephalic vein can also be used if necessary. The catheter is advanced until its tip reaches the superior vena cava, providing reliable central access. PICC lines can be inserted either at the bedside or in interventional radiology by physicians or specially trained nurses. They usually have between 1 and 3 lumens and are longer than CVCS, ranging from 18 to 29 inches or 45 to 72 centimeters. One key advantage is that PICCS are associated with a lower rate of central line-associated bloodstream infections, CLABSI, compared to centrally inserted catheters. In the previous slide, we discussed the basic features of a PICC line. This diagram now shows us the actual pathway. The catheter enters from a vein in the arm, usually the basilic vein, and is advanced upward until the tip reaches the superior vena cava near the heart. This explains why PICCs, though inserted peripherally, are considered central lines. In the previous slides, we introduced what central venous catheters are and how they are placed. Now, let's talk about when we use them in clinical practice. Central lines are indicated for long-term intravenous therapy, such as chemotherapy, parenteral nutrition, or prolonged antibiotic treatment. They are also used for blood sampling, especially in patients with poor peripheral veins. In cases where peripheral IV access is difficult or repeatedly fails, a central line is the best option. In the ICU, one important use is central venous pressure monitoring. Central lines also allow for the administration of incompatible medications, or when multiple infusions of fluids and drugs are needed at the same time. Finally, they are required for solutions that are hypertonic, hyperosmolar, or with extreme pH values, which cannot be safely infused into peripheral veins. In the previous slide, we looked at the indications for central line use. Now, let's compare the two main options, CVC and PICC. A CVC is inserted directly into a central vein, such as the internal jugular or subclavian vein. It is usually chosen for short-term use, especially when higher blood flow is needed, such as in critical care or when rapid infusion is required. On the other hand, a PICC is inserted through a peripheral vein in the arm. It is preferred for long-term therapy, such as prolonged antibiotics, chemotherapy, or parenteral nutrition. Compared to CVCs, PICCs are less invasive at the insertion site, though they require more careful maintenance. So, the choice between CVC and PICC depends largely on treatment duration, patient condition, and clinical goals. In the previous slide, we compared CVC and PICC and discussed when to choose each one. Once the decision is made, the next important step is how to insert them safely. There are several key precautions during insertion. First, use a maximal sterile barrier, including sterile gown, gloves, mask, cap, and a large sterile drape. Second, prepare the skin with 2% chlorhexidine, which is more effective than povidone iodine in reducing infection risk. Third, always confirm placement with imaging, such as chest X-ray or ultrasound, to ensure the catheter tip is correctly positioned and to rule out complications. Finally, it is essential to document all insertion details in the patient's record, including site, technique, and confirmation method. In the last slide, we reviewed the precautions during insertion to ensure safety. Now, let's focus on another important feature of central lines, the number of lumens. Central venous catheters, CVCs, are available in 1 to 5 lumens. Multiple lumens allow simultaneous infusion of different medications or fluids, especially when drugs are not compatible with each other. In critical care, triple or quad-lumen CVCs are very common. PICC lines, on the other hand, usually have 1 to 3 lumens. They provide sufficient access for long-term therapy but are less complex than CVCs. The choice of lumen number should always be based on the clinical needs. The more lumens, the more flexibility in therapy, but also a higher risk of infection and thrombosis. In the previous slide, we learned that central lines may have multiple lumens, ranging from 1 to 5. This slide explains the functions of each lumen in a triple lumen catheter. The proximal lumen, being closest to the external exit site, is best for blood sampling and routine medication administration. The medial lumen is usually dedicated to total parenteral nutrition, TPN, because TPN is incompatible with many medications. If TPN is not planned, it may be used for other drugs. The distal lumen is the largest and closest to the heart, which gives it the highest flow rate. This makes it ideal for central venous pressure monitoring, blood transfusions, large volume infusions, viscous fluids, and colloids. Understanding lumen designation helps us minimize complications, avoid incompatibilities, and improve patient safety. In the previous slide, we discussed how each lumen in a multilumen catheter should be used. Now let's move on to the care of the insertion site, specifically the CDC recommendations for catheter dressings. We can use either sterile gauze or a sterile transparent semipermeable dressing to cover the site. If the patient is sweating a lot or if the site is bleeding or oozing, it is best to use gauze until the situation is controlled. Dressings should be replaced immediately if they become damp, loosened, or visibly soiled, as this increases infection risk. Finally, the CDC recommends not using antibiotic ointments or creams because they can promote fungal growth or antimicrobial resistance. Now let's review the recommended frequency for changing dressings. For short-term CVC sites, gauze dressings should be replaced every 2 days, while transparent dressings should be replaced at least every 7 days, or sooner if they become wet, loose, or visibly soiled. For PICC lines, the first dressing change should occur 24 hours after insertion, because the insertion site may still be oozing. After that, transparent dressings should be changed every 5 to 7 days, unless there is a problem such as loosening or contamination. Gauze dressings should be changed every 2 days. When performing dressing changes, always cleanse the skin with 2% chlorhexidine in 70% alcohol solution, which is the CDC-recommended standard for infection prevention. Now, let's look at the step-by-step procedure for dressing removal and replacement. When removing a dressing, always stabilize the catheter and the luer lock hub to prevent accidental dislodgement. Remove the dressing carefully, working from the outer edge toward the insertion site. Clean the skin with chlorhexidine in a back-and-forth motion for at least 30 seconds. If the patient is very sweaty or the skin is moist, extend scrubbing to 2 minutes for better bactericidal effect. Assess the external length of the catheter during the change. If the length has increased, this may mean the catheter tip has migrated. Finally, apply a new sterile occlusive dressing, ensuring it covers the insertion site, the suture wing, and at least 2.5 centimeters of the extension tubing. In the last slide, we focused on how to safely remove the old dressing. Now, let's go through the general steps for performing a dressing change from start to finish. Begin by gathering all necessary supplies and performing proper hand hygiene. Put on clean gloves and place a mask on the patient to reduce contamination risk. Remove the old dressing carefully, always pulling toward the insertion site. Dispose of it properly. Remove gloves, perform hand hygiene again, and then put on sterile gloves. Inspect the catheter, insertion site, and surrounding skin for signs of infection, redness, or swelling. Cleanse the site with chlorhexidine, scrubbing back and forth, and let it air dry completely. Resecure the catheter, apply a new sterile occlusive dressing, and label it with the date, time, and your initials. Finally, document the procedure in the patient's chart, including the catheter's external length and any complications. In the previous slide, we reviewed the steps for changing dressings. Now, let's shift our focus to needleless access devices, also known as CAPs. According to the CDC, CAPs should be changed at least as frequently as the administration set. For example, if tubing is changed every 72 hours, then CAPs should also be changed at that interval. There is no proven benefit to changing them more frequently than every 72 hours. One special consideration is with TPN or lipid infusions, because these solutions promote microbial growth, so CAPs must be handled with extra caution. Before accessing the line, always remember to scrub the hub for 15 seconds with alcohol or chlorhexidine to disinfect the connector and reduce infection risk. In the previous slide, we discussed how to care for needleless CAPs and the importance of disinfecting them before use. Now, let's look at the different types of needleless connectors. Negative displacement devices create a small vacuum when the syringe is disconnected. This can pull blood back into the catheter tip, increasing the risk of clot formation if not flushed properly. Neutral displacement devices are designed to minimize fluid movement when connecting or disconnecting, thereby reducing the risk of reflux. Positive displacement devices push a small amount of fluid into the catheter when disconnected, which helps prevent blood reflux and catheter occlusion. For example, at Meeker Memorial Hospital, the Baxter ClearLink system is used, which is a negative displacement device. Knowing the type of connector you are working with helps you apply the correct flushing technique to maintain catheter patency. In the previous slide, we looked at the different types of needleless connectors. Now let's talk about the protocol for flushing central lines and PICC lines, which is one of the most important steps in preventing occlusion and infection. First, Remember that a single-use syringe should never be reused. Even if it looks clean, reusing syringes increases the risk of contamination. Do not split a 10 milliliter syringe into multiple doses to flush different lumens. Each lumen must have its own syringe to prevent cross-contamination. Also, never use a syringe smaller than 10 milliliters. Smaller syringes create higher pressure, which can actually damage or rupture the catheter. For flushing volume, the guideline is to use at least twice the volume of the catheter. In most adult patients, 10 milliliters of saline is sufficient for routine flushing. Finally, always use 0.9% normal saline as the standard flushing solution. Heparin may be used in some cases, but saline is the routine choice recommended by guidelines. Proper flushing is essential to keep the line patent and safe for the patient. In the last slide, we learned about the basic flushing protocol, including syringe size and flushing volume. Now let's focus on the frequency and technique of flushing. Frequency. At minimum, lines should be flushed every 8 hours if they are in use. Flush with 10 milliliters normal saline before and after every medication administration. For lines that are not actively used but kept for maintenance, flush with 10 milliliters saline every 24 hours to maintain patency. Technique. Always use a pulsatile or stop-start flushing technique. This creates turbulence inside the catheter, which helps to clear out any residual medication and reduces the risk of clot formation. If ordered, you may apply a heparin lock after flushing, especially for certain long-term catheters. Finally, always clamp the line after flushing to prevent blood reflux. This combination of frequency and proper technique is key to keeping central lines safe and functional. In the last slide, we reviewed flushing frequency and technique, including the use of pulsatile flushing to prevent blockage. Now let's focus on another complication: blood reflux into the catheter. Problem. Catheters are deep inside the body, so when reflux occurs, we cannot see it directly. This makes it dangerous, because it may go unnoticed until the line is already occluded or infected. Causes. Reflux can occur if flushing is inadequate or if intravascular pressure suddenly increases, for example, during coughing, vomiting, or straining. This reflux can lead to biofilm formation, drug precipitation, occlusion, and eventually infection. Prevention strategy. The key prevention method is to know which type of needleless connector is being used. Different connectors, negative, neutral, positive displacement, require different flushing and clamping techniques. Proper technique helps minimize blood reflux and keeps the line patent. In the last slide, we discussed how blood reflux can occur and why prevention is important. Now, let's look at how clamping technique differs depending on the type of needleless connector. Negative displacement. For this type, the catheter must be clamped before the syringe is removed. This prevents blood from being sucked back into the line. Neutral displacement. With neutral devices, the fluid remains stable, so clamping can be done either before or after removing the syringe. Positive displacement. For this type, it is essential to clamp the catheter after removing the syringe. This allows the device to push a small amount of fluid into the line, preventing blood reflux. By knowing the connector type and applying the correct clamping sequence, we can significantly reduce the risk of blood reflux, catheter occlusion, and infection. In the previous slide, we talked about clamping techniques for different needleless connectors to prevent blood reflux. Now let's move on to a broader and very important topic: preventing infections. Central line-associated bloodstream infections, CLABSI, are one of the most serious complications. To reduce this risk, several key strategies must always be followed. Hand hygiene. Proper hand washing or alcohol-based rub before and after touching the line. Disinfect hubs. Always scrub the hub before every access. Closed systems. Use closed force systems whenever possible to reduce the chance of contamination. Minimize duration of line. Remove the catheter as soon as it is no longer clinically needed. The longer the line stays, the higher the infection risk. Routine audits. Regular checks and audits of practice help ensure compliance with infection prevention bundles. Following these steps consistently is the best way to protect patients from central line infections. After discussing infection prevention, let's now focus on the daily care and assessment of central lines. Daily and consistent monitoring is crucial to detect complications early and maintain catheter safety. Key points include visual inspection. Check insertion site every day for redness, drainage, tenderness, suture stability, and catheter position. Routine site assessment. Make sure the site looks healthy and clean. Dressing checks. Ensure the dressing is intact and replace if damp, loose, or soiled. Patency check every shift. Verify the line is patent and flushing well. Daily review of necessity. Ask, does this patient still need a central line? Remove it as soon as it's no longer required. Nurse-physician communication. Nurses should actively inform physicians if a line seems unnecessary. This teamwork approach helps reduce infection risks and prevents complications associated with prolonged catheter use. Now that we've reviewed daily care, let's discuss the common complications of central lines. Understanding these risks helps us detect problems early and act promptly. CLABSI, central line-associated bloodstream infection, one of the most serious complications, caused by improper aseptic technique or prolonged catheter use. Thrombosis, formation of blood clots around the catheter, which can obstruct blood flow. Occlusion, catheter blockage due to blood, drug precipitates, or poor flushing technique. Air embolism, air entering the bloodstream, often during insertion or removal, which can be life-threatening. Dislodgement, catheter migration or accidental removal, which compromises line function and patient safety. These complications remind us why strict aseptic technique, proper flushing, and securement are essential at every step. Finally, let's summarize the nursing responsibilities in central line care. Maintain and document care. Nurses must provide daily care and accurately record every intervention. Documentation is crucial for continuity and legal protection. Monitor complications. Always watch for early signs of infection, occlusion, thrombosis, or dislodgement. Patient education. Teach patients how to protect their line, report symptoms, and avoid unnecessary handling. Communicate with the healthcare team. Nurses are often the first to notice issues, so reporting promptly ensures timely intervention. Timely removal. Lines should be removed as soon as they are no longer needed to reduce the risk of infection. So, nursing care is not just about performing procedures, but about continuous assessment, communication, and patient safety advocacy. Now let's talk about documentation. Proper charting is essential for safe patient care, communication between staff, and medico-legal protection. When documenting central line insertion and care, the following should always be included: product name of the catheter, date of insertion and the name of the inserter, anatomical location of the insertion site, catheter depth, recorded according to the reference markings, X-ray confirmation of catheter tip location, if applicable, port designation for specific uses, e.g., TPN, CVP, medications, to ensure all staff use the lumens consistently. Documentation is not just paperwork. It ensures continuity, accuracy, and safety in patient care. In addition to what we mentioned before, documentation should also include daily care and follow-up details. Specifically, record the amount, type, and frequency of flush solution used. Document dressing and tubing changes, and always note the exposed catheter length after dressing changes. Assess and record the site condition every shift. Document any incidents or complications. Record the teaching provided to the patient, such as how to keep the site clean. When the catheter is removed, document the removal process and the use of an air-impermeable dressing. Thorough documentation provides a complete clinical picture and ensures quality and safety of care. Here we talk about patient education. The key points are the same for both CVC and PICC lines. Keep the site clean and dry. Avoid tugging or pulling on the line. Report symptoms such as fever, redness, swelling, or pain at the site. Do not submerge the site in water. Showering with protection is acceptable. Always attend follow-up appointments for assessments and dressing changes. Please note, CVCs are generally for in-hospital use only and are not taken home. For patients with a PICC line, these instructions are especially important, and when patients go home, they must pay extra attention to these precautions. This concludes today's session on central venous catheter, CVC, and peripherally inserted central catheter, PICC care. We reviewed the key points, including indications and differences between CVC and PICC, proper insertion precautions and dressing care, flushing protocols and infection prevention, patient education and nursing responsibilities. Remember, our ultimate goal is to ensure patient safety and reduce complications. If you have any questions, please feel free to leave a comment. Thank you all for listening.